you mentioned like the virtual surgical planning. I feel like that's a lot more common than when I was a resident. Like I feel like that are you doing that a lot more than you used to, and what does that entail?
Yeah, I did not train with virtual surgical planning. So it's something that I slowly adopted over time, and I tried it out a little bit when I first completed my training because one of my partners was interested in using it, and I kind of didn't like it that much. But then it's improved over the years, and there is a certain amount of learning curve that is required in terms of like learning how to design the cutting guides and design the plates and just like the way you're going to position bone segments. It's a little bit different. And the engineer, you get on this session with an engineer, depending on the vendor that you're using. Usually it's Stryker or KLS Martin or Synthes are the main three that we use. And so you get on a call with an engineer, and they're kind of controlling the like computer assisted design software and manipulating things, and you're trying to direct them what you want exactly. And they do this with many other surgeons. So sometimes they don't really suggest stuff, which I wish they would early on, because sometimes you're just not sure how most people would do X, Y, or Z defect. So there's a little bit of a learning curve that was required as far as like designing the shape of the cutting guides, because they have a lot of different options, and sometimes it's hard to physically fit the cutting guide into the space that you're working in. So you kind of have to know, what works and what doesn't. But after I got the hang of it, I realized it did just help. It does save some time in the OR. Granted, you're using that time elsewhere. It takes maybe a simple case is about 10 minutes to plan, but sometimes they can take 30 minutes or even 40 minutes if it's something complex. So you still are spending that time, but at least you're saving the patient a little bit of anesthetic time. The main reason why I like it is just because it forces you to kind of think about what you're going to do ahead of time, and you have a definitive plan, and you pin down the person that's doing the resection, and you kind of communicate more thoroughly than you otherwise would. And think of like contingency plans and plan A and plan B, which of course you should normally, but it just like requires it to be more precise, because you have to know exactly what tooth, like on the mandible, you're going to make your osteotomy. And then you can see it in 3 dimensions. You can see how the different segments are going to fit together and what degree of asymmetry, because you're taking straight bone segments. It's never going to be perfectly the same shape as a native mandible, which is curved. So you can kind of play with things and see what works better, especially with very long fibula segments. Like if you're reconstructing more than half a mandible and you want to see how much fibula is available, and you might be pushing the boundary of how much fibula you can resect, and then that might affect the resecting surgeon's margins. Sometimes they just want to take some extra, an extra centimeter or two, because it doesn't really affect the patient at all. But if you can't reconstruct that as well, then that might influence that decision. So that's something you wouldn't really know ahead of time unless you were like really, really good at just looking at the images and being able to tell those small distances in your mind. Just the fact that it forces you to plan the case out in your mind ahead of time is really why I like it, because then you're just kind of executing on the day of surgery. You're not really thinking about how you're going to solve the problem. You're just kind of doing the technical things, unless the plan changes, and occasionally it does.
And this is on the computer, or are you wearing like an Oculus?
No, it's just on the computer.
Okay, I'm like, are we printing?
I have a holodeck, and I like go inside it.
Are you in the metaverse at this point?
I just
where
text
are we?
My friend Zuck, and he just like pulls it up on the Facebook, and then we go to town.
Okay, cool.
And that's mostly, you're talking mandibles, fibula reconstruction of mandibles is mostly when you're using the virtual planning.
Bony
Anything
reconstructive
bone?
cases, so mandible or midface, and I find it pretty helpful for the midface because of the fact that it's more complex to kind of, especially like a total maxillectomy with orbital preservation is one of the more complex bony reconstructions that we do, just because we're trying to maintain the position of the eye, and if you drop the eye by a couple millimeters, they might start getting diplopia. It's a more cosmetically sensitive. It's just like a more complex shape, and then you also have dentition that you have to worry about as far as dental rehabilitation, and then the nasal airway too. So those are more challenging. A few millimeters makes more of a difference than it does on a mandible. So the other thing that I didn't mention before is, so when we do the virtual surgical planning, we can create a model of the defect. So then we can plate our construct like in the model, and we can put all our little plates on, especially for the midface.
Physically or virtually?
physically. Like in surgery, we have a model of like a plastic model of the bony facial skeleton with the resection done already. So it's missing the resection. So you have basically a plastic model of your defect. And then we can take, like if it's a 3-4 segment midface bony reconstruction, we can then plate all the bone fragments together and cut them and shape them and plate them to the plastic model, using the plastic model like as the fake inset. And so then you have all your bony fragments plated together, and you can just take that whole thing as like an already prefabricated construct, and then you can bring that up to the face and just pop it in. And so that allows us to do more of a minimally invasive approach for total maxillectomy, where we can just do like a midfacial degloving and transoral incisions and transnasal incisions and avoid making incisions on the face. Whereas if you don't do that, it's just very hard to kind of get the screwdrivers in the angles that you need, and you can't just kind of control the segments and get them into position. So this makes it a little easier to like work through a smaller cavity when we're doing the plating.
Yeah, that makes sense.